Hello, welcome to SPMM Revision on Demand. In this podcast, I will discuss the concepts surrounding Kaplan-Meier curves. Before going on to a Kaplan-Meier curve, we must first understand the concept of survival analysis. Most clinical trials are interested in assessing how often does an event such as treatment response or relapse occur when a group of patients receive a new treatment. In some clinical trials and cohort studies, the time taken for an event to occur is more important endpoint than the differences in the frequency of occurrences of the event. For example, how long does the MMSE score remain stable after starting anti-dementia drugs? How long does a patient survive without having stroke when statins are prescribed? How long does a patient with depression remain free of a relapse when he is given antidepressants, etc.? These questions can be addressed by graphically plotting the function of time against proportion of patients surviving an event of interest. When I say surviving patients, I mean these patients are not experiencing an event of interest. The event could be either a positive event such as treatment response or a negative event such as death or relapse. Such a plot is called the Kaplan-Meier survival curve. To construct a Kaplan-Meier curve, you need two sets of values. On the x-axis, you plot the time of observation. On the y-axis, you plot the actual number or the proportion of patients not experiencing the event of interest at a given time. To consider an example, assume conducting a trial of depot antipsychotics in a cohort of patients with schizophrenia. We are interested in the time it takes for extrapyramidal side effects such as dystonia, tremors, and rigidity to appear after initiating the antipsychotic depot. In this figure, I have plotted the time since the trial began against the proportion of patients that do not show any evidence for extrapyramidal side effects. At the beginning of a study, that is day 0, no one has responded to treatment yet. No one has developed extrapyramidal side effects as well. But by day 20, see the slide, but by day 20, when a neurological assessment for EPSCs was made, around 9% of patients was noted to have EPSCs. This is shown by a step dropping downwards. By day 35, when another neurological assessment was made, more patients with EPSCs were detected. This proportion increased further by day 50, with 62.7% of patients not having EPSCs yet, while the remaining have developed EPSCs. This is the proportion that survived, 62.7%, by day 50. The study ended on day 60. There were no new reports of EPSCs on day 60 when compared to day 50. The probability of surviving without EPSCs up to 60 days after antipsychotic depot injection is 62.7%. So this is how a Kaplan-Meier curve is constructed. A term that is often used in the context of survival curves is censoring. For a number of patients in the previous cohort, we could not determine how long they would have lasted without EPSCs when depot antipsychotics were given. This lack of data is termed as censoring. Censoring occurs as we cannot practically continue a study for the long time period required for the last person to develop the event of interest. It can also happen when a subject drops out of the study due to various reasons. In this slide, you can see how some researchers choose to depict dropouts. Each spike represents the time that one patient was lost to follow-up. The patient pointed here had just 2 years instead of a full 5-year follow-up. The spikes must be differentiated from the steps. Each step in the Kaplan-Meier curve is a point where an observation has been made and new events have been identified. In this example, 2 groups are observed for a period of 5 months. In group 1, most but not all subjects have developed the event of interest by 5 months. That is, nearly 20% survive by the end of the study. In group 2, All subjects have developed the event of interest by 3.5 months. That is, no one survives till the end of the study. 50% represents the median proportion in a group. How long did 50% of group 2 patients manage to survive? You can see that they survived for up to 2 months. This is called median survival time. How long did 50% of group 1 patients manage to survive? You can see that they managed to hold up for up to 4 months. The intervention given to group 1 has improved their survival chances. But is this a significant improvement? There are two statistical approaches that are commonly used to assess statistical significance of the difference in survival rates. The first of this is log rank test. One of these, out of these, the most popular method for comparing survival of two groups is the log rank test, as I mentioned earlier. This is a test of statistical significance of the difference in the overall survival experience of two groups. It does not provide an effect size or confidence interval. The second test is called Cox regression or Cox proportional hazards test. Hazard rate is the probability that if the event in question has not already occurred, it will occur in the next time interval, divided by the length of that interval. We can compute this for each group separately. Hazard ratio is an estimate of the ratio of the hazard rate in the two groups that are being compared. If the hazard ratio is 0.5, then the relative risk of event in one group is half the risk of the same event in the other group. Cox is a multivariate regression method that can take into account the effect of confounders when comparing the hazard rates. Moreover, unlike log rank test, Cox proportional hazards test can provide an estimate of the effect size and confidence intervals as well. Sometimes you may come across curves that look like Kaplan-Meier but look somewhat different. The steps do not go downwards in this plot, but they are ascending. Instead of plotting the proportion surviving, the researchers have plotted the proportion experiencing the event of interest on y-axis. Now it's time to ask yourself a few questions. Look at the plot shown here. Thank you for choosing SPMM course for your revision.